LDL is not the number that drives heart attacks. ApoB is. And because conventional medicine still defaults to a basic lipid panel, while influencers tell you cholesterol doesn't matter at all, most people are flying completely blind about the one marker that would actually tell them their real risk. Your doctor checks your LDL and tells you your cholesterol is fine. Influencers tell you your cholesterol doesn't cause heart disease anyway. Both of them are wrong. And the number that actually matters is one most people have never checked. Well-meaning patients and doctors have been making decisions about your heart based on a number established 50 years ago. I'm a triple board certified cardiologist, cardiology, holistic medicine, and coronary CTA. I spent 20 years inside conventional cardiology, ordering the same tests every other cardiologist orders. And after thousands of patients, I stopped fully trusting the standard lipid panel. The LDL measurement itself is answering the wrong question. Once you understand which question that is, you will not look at a standard lipid panel the same way again. I'm going to show you why LDL misleads, what the number that actually predicts your risk measures, and why the influencers telling you cholesterol doesn't matter are getting people hurt. The standard position has been straightforward for 50 years. Check your LDL. If it's high, your cholesterol is a problem. If it's in range, you're probably fine. Lower is better. That is the framework conventional medicine has been running on. LDL became the default because it was measurable. It correlated with heart disease in large studies, and it gave doctors something concrete to act on. When the early statin trials showed that lowering LDL reduced heart attacks, it seemed to confirm the whole model. LDL goes up, risk goes up. LDL comes down, risk comes down. That logic held well enough to become dogma. And once something becomes dogma in medicine, it takes a long time to replace even when better tools exist. Here is what that model was never designed to find. Cholesterol does not damage your heart directly. What happens is that certain particles in your bloodstream push through the endothelium, the lining of your heart arteries, and then into your artery walls and get stuck there. Over time, that buildup becomes plaque. When that plaque ruptures, it triggers a clot. That clot blocks the artery. That is a heart attack. So the real question was never how much cholesterol is in your blood. It was always how many of those particles are hitting your artery wall. LDL was never measuring the right thing. It was never designed to. And here's something most people don't know. The LDL number on your standard lipid panel is usually not even directly measured. It is calculated from a formula developed in 1972. In people with high triglycerides or insulin resistance, that calculation can be significantly wrong in the direction that makes you feel safer than you are. So now an entire corner of the internet has overreacted to the advancements in understanding cholesterol, and they are telling you to completely stop worrying about cholesterol. And that argument is not just wrong, it is dangerous. The influencer argument goes like this. We know LDL measurement is outdated, and saturated fat and cholesterol have been unfairly villainized. Plenty of people eat high-fat diets and never develop heart disease. The whole cholesterol narrative is pharmaceutical industry propaganda. Relax, eat the steak, have the bacon, have the butter. This argument got popular because it contains a kernel of truth. Some people do eat high saturated fat diets and don't develop plaque. And for people who have felt judged or confused by conflicting dietary advice for years, someone confidently telling them none of it matters is genuinely appealing. The argument spread because it felt like liberation. Here's what that argument leaves out, though. The people who are eating high saturated fat and who did not develop plaque are people whose particle count does not rise in response to that diet. For a significant number of people, though, it does. There are people whose particle count climbs a lot on a carnivore or keto diet, and they are building plaque, while an influencer who has never examined them, never checked their labs, never looked inside their arteries, tells them they're fine. You do not know which type of person you are until you measure it. Neither does an influencer. So if LDL is a wrong number and the influencers are using the wrong argument, What does actually measuring your real risk look like? It starts with 2 specific numbers that between them tell you a lot more about your cardiovascular risk than just a standard lipid panel. That answer is coming. But first, if this is landing differently than what you have been told at your last physical, please subscribe. Every week, I put out content on the specific gaps between what the standard cardiac workup checks and what your heart actually needs someone to find. You can have normal cholesterol and still be at high cardiovascular risk. That's because standard lipid panels often miss some of the biggest drivers of plaque buildup, including 1, ApoB, and 2, lipoprotein A. But heart risk is never just 1 or 2 numbers. It's a combination of cholesterol particles, inflammation, metabolic health, genetics, lifestyle, and what's actually happening inside your arteries. Remember what we established. Plaque builds when particles push through your artery wall and get stuck there. The question that actually matters is how many of those particles are hitting your artery wall right now. That is what ApoB measures. There's exactly 1 ApoB molecule on every single particle capable of entering your artery wall and starting the plaque building process. When you measure ApoB, you're counting the actual threat directly, not estimating it from a 50-year-old formula. 2 people can have identical LDLs with completely different ApoB levels. One is at a low risk, the other one is at a high risk and building plaque right now. ApoB tells you which one you are. LDL cannot. And unlike LDL, ApoB does not get distorted by your triglyceride level or your metabolic pattern. It is a direct count. It is the same number regardless of what you ate before the blood draw. The second number is different. Lipoprotein A is genetic. It does not change with diet. It does not respond to exercise well. Most medications barely even touch it. If it is elevated, you have a higher baseline risk of plaque formation that operates independently of everything else you are doing right. It is not a lifestyle problem, it is a genetic one. And because it does not change, you only need to check it once in your life. But you do need to check it. Because if it is elevated and nobody has told you, you are managing a risk you don't even know you have. I know this personally because I'm vegetarian, I have an ideal body weight, I exercise. By every external measure, my cardiovascular risk should be low. I have elevated lipoprotein A. I did a scan on my own and I found soft plaque. Not because I was doing anything wrong. Because of my genetics and because menopause accelerated it. And testing for the right things helped me find it before it was too late. So 1 number tells you how many particles are hitting your artery wall right now. The other tells you whether your genetics are working against you regardless of your lifestyle. Neither one is on a standard lipid panel. Both of them are available at most labs. And most doctors are still not ordering them. I want you to stop treating a normal LDL as a complete picture of your cholesterol risk. It is 1 estimated number from a decades-old formula, answering 1 narrow question about 1 aspect of your lipid profile. These other blood tests are not exotic, they're not experimental. The research supporting both of them is extensive. The only reason you have not had them is that nobody ordered them. Here's exactly what to say at your next appointment so that does not happen again. When you know your ApoB and your lipoprotein A, you stop making decisions about your cardiovascular risk based on a partial picture. You know your actual particle burden. You know whether your genetic baseline is working against you regardless of your lifestyle. And if something is elevated, you have a specific, measurable target to work toward. That is precision medicine. Before your next doctor's appointment, do this. Write down whether you have ever had an ApoB or a lipoprotein A ordered. If you're not sure, call your doctor's office and ask them to check your last 3 years of labs. Write down 2 specific requests to bring into your next appointment. I would like an ApoB added to my lipid panel, and I have never had my lipoprotein A checked, and I would like to get it done. If your doctor says those tests are not necessary, ask them directly. So if my ApoB is elevated despite a normal LDL, would that change your assessment of my risk? A doctor who understands cardiovascular risk will say yes. That answer also tells you something important about the conversation you are in. If you have been following a high saturated fat diet based on advice that cholesterol doesn't matter, get your ApoB checked before you continue it. LDL became the default because it was the best tool available when the field was built. A better tool now exists and has existed for years. ApoB is not experimental. It is not controversial in the research literature. It is not yet the default in the standard 10-minute appointment. That is the gap between what cardiology knows and what patients get. You now know what to ask for. Go ask for it. If you want to understand what the other numbers on a complete cardiac workup actually mean and which ones move the needle most, the previous video on this channel walks through exactly what I check on every new patient that most doctors never order and is appearing on your screen now.